Hello, I'm Dr. Sean Mackey, and I'm excited to have you join us here for our focus group related to our research project that I'm going to describe to you over the next several minutes. By way of introduction, I'm a professor and chief of the Division of Pain Medicine here at Stanford University. I'm a physician scientist, which means that I do both research and I care for people who are in pain. I've been here for over 25 years, and a good part of my life is spent trying to unlock the mysteries of pain to better advance our scientific knowledge and then translate that knowledge into safer and more effective treatments for people suffering from chronic pain like yourself. So this particular project, I'm the principal investigator of, which simply means that I'm responsible for its execution and for making it happen successfully. And in doing so, we're relying on you to help advise us. We want this to be a patient-centered project. We want your input, and we're going to put it to good use. We're not simply giving it lip service. Why are we doing this project? Well, if you will, allow me to walk you through a little bit of my vision for where I see the world regarding pain medicine and the care for those people who are in pain. And if you will, I want you to imagine a world. Imagine a world where clinicians have access to high-quality data and state-of-the-art technologies to better inform their assessments and their treatments for each individual person, where new technologies are developed by scientists, engineers, they're informed by patient input like yourselves, they're integrated into clinical care, and then the clinician and patient experiences inform how we optimize these technologies, and we do that in a cyclical or iterative approach, where researchers are working with real-world patients, much like we're doing right now, to generate findings that generalize to a broad population and not just simply those very filtered, homogeneous populations that we usually study in clinical research. And then finally, and perhaps most importantly, where people like you have access to your own health information to help improve your education, your management of pain and other conditions, where patients are working collaboratively with us to ultimately empower your individual care. That's my vision for where we want to go, and that's in part what this project is all about. It's to help us move the next steps forward to achieving that vision. So allow me to give you a little bit of background about chronic pain. I was on an Institute of Medicine committee that wrote this book, Relieving Pain in America, where we identified that about 1 in 3 Americans have chronic pain. That's about 100 million Americans in society, and we spend over $500 billion each year in the care of people who have chronic pain. That's an astounding number of people and a huge impact on the individual, their families, and society as a whole. That is, by the way, more than diabetes, heart disease, and cancer combined. More recently, I helped lead an effort for the development of a national pain strategy for our country. As part of that, we defined a new term called high-impact chronic pain. Now, high-impact chronic pain is that pain that has substantial participation restrictions due to pain in work, social, and self-care activities lasting 6 months or more. You can think of this pain as being the most severe of the pain, and maybe either you fit yourself into that category or you have friends or loved ones that do. These are the ones who have a tremendous impact as a consequence of their pain, and we want to better understand and do something about this. Now, the problem that we have in chronic pain is that there is a huge unmet need, and we need better medications, better tools, better treatments. But the problem is that very few of those that start off here in these early phase discoveries, these are early preclinical or animal studies on new drugs, very few of these ever actually get to approval. Only a very tiny portion of them ever make it to approval. And that's a problem, and we need to improve that success rate. And how are we going to get there? Well, it is through this concept of precision medicine that we want to achieve. And it's the idea of delivering the right treatment to the right person at the right time So it is tailoring the treatments for each individual person, because it's possible that while only a small number of these people on average respond, there may be a larger group within there, a subgroup of people that would respond to a particular treatment. To get there, we're going to have to develop something called biomarkers. Now, biomarkers have a definition. They're defined as a characteristic that is objectively measured and evaluated as an indicator of normal biologic processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention, which is it's a tremendous mouthful, let's face it. So really, let's just distill it down. What is a biomarker? A biomarker is just something that we measure physiologically. It could be your heart rate. It could be blood pressure. It could be some molecule or chemical that is in your blood. It could be some response when we test you to a certain stimulus, if we give you a heat stimulus. All of those are biomarkers. And what we need to do is better develop these type of biomarkers. Now, I'm going back to the slide I showed you before, where they take all drugs, all comers, and you see this terrible final approval rate. But if, in fact, what you do is you integrate in biomarkers where you can select out those groups of people that really do respond, what we find is a rather dramatic increase in the number of drugs that actually reach approval. Now, this is just an example using medications. Our goal is to apply these biomarkers to all treatments. We want to be able to identify objective biomarkers so that we can figure out which of the many treatments we have in pain, from medications to procedures to mind-body therapies to physical therapy approaches to complementary alternative medicine approaches, which of those work best for your particular condition. Not necessarily the next person's condition, but for yours. And that's the whole basis of precision medicine. And that builds us up to why we're doing this study. What we're looking to do is to develop biomarkers for high-impact chronic pain, that most severe of pain. And the NIH, through taxpayer support, has provided us with funds for this discovery phase, in which we're going to go out and identify these biomarkers. And what we're going to do, and I'll say this several times, is we're going to be applying a number of different biomarkers, from sensory testing, which I'll discuss briefly, brain imaging, which we do a lot of. We're going to be sampling blood and the microbiome. We're going to be asking a lot of survey questions, and then we're going to have people do wearables to measure physical function and sleep, heart rate variability. And that's the nature of this study. The team that makes this up is, as you see here, we have an incredibly gifted team of researchers. And what I'm most excited about this is it is a multidisciplinary team, meaning I like being surrounded by people in other fields that are a whole lot smarter than me, because when we look at pain from a 360-degree perspective, we understand more of it, because pain is so complicated. There's no one person who can understand everything. So we have the chair of Stanford genetics, Dr. Snyder. We have Beth Darnell, an internationally renowned pain psychology researcher, Jamie Zeitzer, an internationally renowned sleep researcher, Dr. Ming Cao, who's a Harvard-trained biostatistician and the Stanford Pain Center clinic chief, Dr. Kong, who's an expert in quantitative sensory testing, Dr. Salmasi, who will be our medical director, Dr. Leskovitz, who is a true whiz when it comes to machine learning techniques, which we're going to be using to build these models up, and Dr. Tien in statistics, and Dr. Weber in neuroimaging. And then also what you'll notice here is we have on our team people with lived experience in pain who lead patient advocacy groups. So we have Penny Cowan, who is the president of the American Chronic Pain Association, and we have Christine Veasley, who is the president of the Chronic Pain Research Alliance, who is helping to inform us. In fact, it was their idea to put together these focus groups and to reach out to people like you. Now, the study design is as follows. We're going to be capturing 6 different set of samples at a variety of time points, 5 different samples at different time points. We're going to be getting at baseline, 1 month, 2 month, 3 month, and then it's 6 months out. And by and large, we're going to be getting the same samples at each of these, with the exception of the neuroimaging. When we bring people in to have a brain scan in the MRI, we're only going to do that at baseline. And the reason is because it's a bit cumbersome and it adds an extra couple hours. And we only want to do that once. But at each of these time points, we're going to be capturing what we call patient-reported outcomes, PROs, and these are surveys. We're going to ask people to sit down and fill out a lot of surveys. We're going to be doing quantitative sensory testing, which is we're going to be giving them heat stimuli and cold and also a little pinprick, and we're going to be asking them how they respond to it. We'll be measuring actigraphy and a lot more, and we'll be doing that through watches both on the wrist, and then we're going to have them on the hip. And then where you see omics, omics means that we're going to be capturing both blood as well as stool for microbiome, and we're going to do that at each point. And as I mentioned, the neuroimaging is only at one point in time. And then we're going to collect all this information, analyze it, and build models to ultimately be able to predict a person's future state. That's one of the major goals, is can we build a trajectory of these biomarkers to predict whether somebody will get better or get worse. From this, we're going to build on it to determine whether somebody can respond to a particular treatment or not. Now, these are examples of the different biomarkers that we are collecting. As I mentioned, we're getting neuroimaging, sensory testing, a variety of omics, wearables. We're going to be asking a number of questions, and we'll be getting some additional metrics as well. This is simply a repeat of that particular study. So that's a rather quick rundown of where we stand. And again, the goal of this is to build these models where we can predict an individual person, how well they're doing from a severity standpoint, how they're going to do in the future, and then ideally use that information to guide treatment decisions. Now, what we're going to be asking you to do throughout this is we want your advice. We want to know what you think of the merit of the study. Does it make sense to you? Have we explained it well enough? We want to know about the burden of the study to you. In other words, is asking people to come 5 times to our lab, is it reasonable? Now, we are going to reimburse people for this, and we're paying a pretty decent amount of money from a standpoint of most reimbursements, but the truth is your time is incredibly important, and it doesn't fully capture your time, and we recognize that. We have limits on the budget for what we can pay people. We're going to want to know what you're willing to tolerate with regard to wearables. Will you wear something on your wrist for the entire time? Will you remember to wear it? Will you come into the lab, or should we try to find options to have you go to a local Quest lab or other lab to get blood and a stool sample drawn and to drop off? Or should we try to do ride sharing? Would that make a difference for you? Instead of your driving to our site, what if we paid to have Uber or Lyft pick you up and bring you over? Would that make a difference? Ultimately, what we have to do is find a way to optimize this study. What we find in research is that recruitment, enrollment, and retention are the bane of our existence. We need to get people in, and we need to keep them in, and we need to keep them engaged with the study. And we need your advice on how to best do that. So with that, I'll thank you for your time. I appreciate the time that you're going to be giving us. You'll enjoy meeting with our team, and we'll be delighted to answer any questions for you. And with that, I'll thank you and wish you all well. Bye-bye.